Yeah, I can see it. Actually, now, actually new on it. So what we want to do is take a look. We want to, I'm gonna close that. Just so that doesn't get confusing. Now, that. We want to go back to the field. Okay, so I'm going to click here. Here's the screen we want to share. So the sharing video of moving on your side, click on that.
Okay. So now.
Now I'm going to, as the public, all right, so it looks good. I can now the slides down.
But now, am I showing the slideshow right away? No, what I'm saying is, as soon as the meeting starts, it might. And is the slideshow already going to be up?
Yeah.
Okay.
Trying to see you're getting on and yeah, okay. Yeah. So yeah, you're good. So on your second monitor, you have all so right now it's sharing the PowerPoint. So we're just going to advance the PowerPoint as we do,
We're just trying to test.
Yeah, that's great.
Now, if you want someone else to join in, I don't want to go in.
He's right here with me. But how do I move the slide on this?
I think
Yeah. Oh, enter. Oh, okay. There we go. Okay. Okay.
And then if someone else needed to share screen, is there a way to do that too?
You can pass the sharing if you want, where
multiple
participants. You just might get a little like you got your own with that, you know. Get that the first basic goal, logic have it just depends if you want to do that or not. So we can do multiple participants if you want. Then you would have to select, and then you can grab control again. And anyway, it depends how much complexity you can do. It's up to you.
Okay, so now when I go right now, we're off of YouTube.
Nope, not.
But we're gonna get off and get back on.
No.
Oh, so we're just gonna leave it like this till 9.
Although hopefully we can delete all this test stuff.
You could probably, you're right, yeah.
Well, the recording, what you're doing, recording, you're gonna, when you want to start recording,
Oh, so we're not recording it.
No, we're not recording. We're on YouTube Live though, but probably nobody's on there anyway.
Yeah, oh, that looks like CTN's on, which is fine.
Wait, where is the? Record to the, okay,
Oh, when it's time.
when it's time, right?
That's what's gonna, video file it. Website.
Okay, and that's right. Now, are we letting the participants in or do they join automatically?
It's just join automatic, just like, think it's not like like 10 minutes before.
Okay.
So like 10 minutes, 5 minutes before the meeting.
Okay.
And I'm gonna be on mute, right?
Good morning.
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 Morning, everyone. We'll get started in just a moment. Morning, everyone. We'll get started in just a moment. We'll take a couple more minutes to collect people. If folks at the DSS host site could give me the go-ahead on the technology, then I know that I can get started. We'll take a couple more minutes to collect people. If folks at the DSS host site could give me the go-ahead on the technology.
Hi, this is Heather Ferguson Hull, just putting on my previous hat as a clerk. Whoever is recording might also have the YouTube stream open right now, so whoever is recording the meeting might wish to close that, and that would take care of the delayed repetition of what the person said previously.
Let's wait for the slide share until we get to agenda item number 3. Thanks for your patience with the technology, everyone. Thank you. And I'll just wait for the green light from the DSS host site to get started. If everything's working, I will kick it off. Okay. We will kick off the meeting. So this is the 340B Workgroup meeting pursuant to Public Act 23-171. Just a note for everyone that this meeting, and I think you must have granted permission if you're in the meeting, but just as a reminder, this meeting is being live streamed. It's also being recorded. And we will, I just want to make sure that folks are aware that that's the case. I want to start out with some introductions. We'll go around. I will call out the first names, and if I don't pronounce it right, please forgive me and please correct me. But I will start on my side. My name is Mehul Dalal. I'm the Chief Policy Advisor for the Department of Social Services. I'll pass it over to Drew, and then I'll keep hosting the Passover so we get everyone. So Drew, go ahead.
Thank you, Mehul. Hi, folks. Glad to be joining you this morning. I'm Drew Katine. I'm a senior policy consultant with the National Academy for State Health Policy.
To Sabrina.
Hi, I'm Sabrina Griswold. I'm the Director of Pharmacy for First Choice Health Centers, a federally qualified health center in East Hartford.
Over to Joel.
Hi, good morning. Joel Norwood, Deputy Policy Advisor, Department of Social Services.
To Paul.
Paul Kidwell, Connecticut Hospital Association.
Elizabeth.
Hi, I'm Elizabeth Benton, Chief of Communications and Policy in the Office of the Attorney General.
Heather.
Good morning. I'm Heather Ferguson Hall, Planning Analyst at the Health and Human Services Policy and Planning Division at the Office of Policy and Management.
Fatmata.
Good morning. I am a Director of Medical Administration at the Department of Social Services.
Thanks. Michaela.
I am Michaela Rosenberger. I'm an Assistant Legal Director at the Department of Social Services.
And Herman.
Good morning. I'm Herman Krantz, Pharmacy Manager at the Department of Social Services.
Jalmar.
Good morning, everybody. Jalmar Didios, Director of Communications, Legislation, and Regulations at DSS.
Nicole.
Good morning. I'm Nicole Godburn, Fiscal Manager of Reimbursement and Certificate of Need with DSS.
David.
Hi, good morning. Dave Seifel, Legislative Manager at DSS.
Felipe.
Good morning, everyone. Felipe Moreno, 340B Program Manager at Community Health Center, FQAC.
Trish.
Good morning, Trish McCooey, Assistant Attorney General in the Health and Education Unit at the Office of the Attorney General.
Guy.
I'm Guy Woolston, Medicaid Director, DSS.
Cindy. We'll get back to Cindy. Kara. Or Kara.
Morning, Kara Pastero from the Office of the Attorney General.
Carla.
Good morning, Carla Tarikian, Assistant Attorney General in the Government Fraud Section.
Senator Summers.
Yes, I am driving, so I can't show my face, but I am Heather Summers. I'm the former chair and now ranking member of Public Health. Looking forward to this group.
Dr. Gifford.
Good morning, everyone. Deidre Gifford, Connecticut Office of Health Strategy.
And I apologize, I don't know if this is a member of the group, but Lena Bahar, is that? I don't know if that's one of the recordings. Okay.
Good morning, Lena Bahar from the Connecticut Insurance Department.
Great, thanks for joining. I'll try Cindy again. Cindy, are you able to introduce yourself?
Cindy DeBue Gallo, she might have had to step away. She's the legislative liaison from the Office of Health Strategy.
And I also want to acknowledge Bernice Perez from our office, who is providing on-site support for the technology, which hopefully will work smoothly. So good morning, everyone. Welcome, and thank you for agreeing to participate on the work group. I just want to acknowledge that if we have a couple minutes at the end of this time, we do want to go through and just kind of identify who the official work group members are. I think a lot of folks, when we sent out the invitations, they either designated someone or are designating someone and also participating. So we just want to straighten that out at the end, and we'll get a updated and accurate work group list to folks, hopefully after the end of this meeting. But either way, I appreciate everyone who's participating on this meeting. Just to review the purpose of this work group, if you will indulge me, I will read the statute. It's not that long, but I just want to make sure we're on all the same page and we have it for the record. that everyone here is gathered for the specific purpose. So we are here pursuant to Section 16 of Public Act 23-171. And I'll read the relevant portions of that. The Commissioner of Social Services shall convene a working group to evaluate 1, the current status of the federal 340B drug pricing program authorized by 42 USC 256B as amended from time to time. 2, national efforts to strengthen and sustain such program. 3, opportunities for state action to protect 340B revenues of federally qualified health centers from unfair administrative barriers or unnecessary conditions based on such center status as a 340B covered entity. Such evaluation shall consider A, the ability of any legal precedent for states to regulate the conduct of drug manufacturers and pharmacy benefit managers as defined in Section 38A 479 AAA of the General Statutes. B, opportunities to facilitate patient access to on-site pharmacies of a federally qualified health center. C, opportunities to establish on-site pharmacies across federally qualified health centers. And D, national trends to sustain such a program. As used in subsection 340B covered entity means a provider participating in the federal 340B drug pricing program authorized by 42 USC 256B as amended from time to time. Not later than January 31st, 2024, the Commissioner of Social Services shall report in accordance with the provisions of Section 11-4A of the General Statutes on the findings and recommendations of the working group to the joint standing committees of the General Assembly having cognizance of matters relating to insurance, public health, and human services. Thank you for that indulgence as I read through it. But just to summarize, DSS is charged with leading this group, and the members of this group will provide us with the content and the input and the feedback necessary to produce the report by January 31st, 2024. So we anticipate that we will get the content during the course of these meetings. We anticipate we will need 2 additional meetings to complete our gathering of the feedback and the information that we need from the participants. We, of course, between meetings, we may reach out to folks individually if we have areas of the report that we're not complete on or we need additional information on. We'll talk a little bit more about the process at the end, or if there's any questions about that. I think the majority of you, your time commitment will be limited to the meetings that we have. Some of you we will reach out to separately, or we'll have a little bit of homework between meetings to make sure that we get the information we need to fulfill the obligations of the Act. Are there any, just briefly today, what we're going to do is we have a few speakers that will provide a level set and overview, and we're very happy to have them. But before I do the introductions, I want to make sure that folks don't have any questions or comments on the overview. All right, hearing none, we are lucky to have the participation of Drew Gatine, and if I don't say that right, please correct me, from the National Association of State Health Policy. Drew has been very much involved and an expert as much as one can be of this complicated program at 340B. So he has agreed, 1, to participate in this work group, which is a great resource for us, and 2, to kick us off with a level set and overview of the 340B program. And I will pass it over to Drew. If I missed anything in the introductions, please feel free to stay a little bit more, and then you can jump into your presentation. And then after your presentation, we'll have some time for questions.
Great. Thank you, Mehul. Thank you, everybody. Really, really excited and privileged, really, to be participating in this group. It makes me a little bit nervous as when anybody refers to me as an expert in 340B. At NASHB, we have been diving into this topic quite a bit over the last couple of years. At NASHB, just for folks that don't know, what we do is we convene states to talk about issues surrounding health policy. And specifically, one of the things we do on the prescription drug and on the cost side is track legislation. So a lot about what I'm going to talk about today is probably going to be a little bit elementary for people that really understand the program. But if you don't understand the program, I think it's really just going to be a level set things that have been happening in the states and really why states are interested in this topic. So Mayo, do you want me to share my screen with my slides? Is that better? I sent some updated.
I'm going to defer to Joel on how the technology is set up.
Okay.
Bernice, if you're able to pull up the slides, that'd be great. Otherwise, we can enable multiple screen sharing.
And I sent Mayo some very some updated slides very early this morning. Do you know if these are those slides or are they the ones I originally sent last night?
They might have been the earlier version.
I mean, they're not really all that different. I think I can talk through the changes unless you want me to just share my screen and use the more updated slides.
All right, just give me a second, see if we can enable multiple screen sharing. Just hold on one moment.
Sorry. Why don't I just start, Mayo, if that's right, because again, I don't think that this slide changed.
Okay, yeah, please go ahead.
Really, so again, I think the first question, that we would ask ourselves that NASHB and would be interested of interest to this group is why are we talking about this topic other than the specific mandate in Connecticut? I don't really think that if 10 years ago states were convening groups like this to talk about 340B, and I think that first bullet point really tells you the primary reason why states are becoming much more interested in this topic. It has grown dramatically over the past few years, over the past 10 years or so, and I'll show you some information about that in a minute. To the point where it's really become very impactful to states as they are trying to figure out ways to reduce costs, particularly RX drug costs. There are a lot of efforts within the states to take action around reducing drug costs, and as these various initiatives and bills move through legislatures, they are addressing questions from covered entities who are very interested, for obvious reasons, as to what the impact would be of legislative changes around RX pricing to their ability to continue to participate in the 340B program. States, of course, are also looking for opportunities to increase access and treatments for people who have low incomes or are uninsured, and I think a lot of states are really trying to focus in on whether drugs purchased with 340B discounts are really being used for the benefit of that population. Obviously, the issue of healthcare, health system consolidation is a hot topic in states, and I think there's a thought out there that the growth of the 340B program, the availability of it, is a factor in those consolidations, and I think states want to understand that. And I think the growth of 340B has reduced Medicaid rebates.
Yeah, I think so.
There's
You need to just email
there's
me,
a
but I think it's going.
there's a pro.
Oh, just one moment, Bernice. You might want to mute yourself.
So there is obviously a prohibition, what's called double dipping, between states cannot claim the Medicaid rebate for a drug for which that has already been purchased by the original provider of the drug using a 340B discount. So as the 340B program has grown, some states have seen that it's really reduced the value of their Medicaid rebates, and again, in various ways, that has certainly impacted policy decisions in those states. And we can go into any one of these things, I think, in more detail as this group does its work. Go to the next slide. Program's now 30 years old, enacted by Congress back in 1992. And again, it basically provides mandatory discounts from drug manufacturers to covered entities. And, I don't know whether you look at it as a carrot or a stick, but manufacturers have to participate in 340B if they want to participate in the Medicaid drug rebate program. And there's this language that folks really focus on that talks about, really the intent of Congress when it enacted this law, and that is to enable covered entities to stretch scarce federal resources as far as possible, reaching more eligible patients and providing more comprehensive services. It really is a federally administered program, which again, I think is one of the reasons why historically you have not seen states, really taking a lot of action related to 340B. And as you track some of the litigation activity around the country, sort of this interplay about what the limits are of what states are allowed to do certainly comes into play in terms of whether or not state action is preempted by the federal statute. Go to the next one. So the discounts are significant, 23.1 of average manufacturer price, but those discounts can go up for drugs as prices rise higher than inflation. And there's even a situation where very expensive drugs and highly utilized drugs like Humira can be made available for the cost of a penny per unit when the price of a drug increases faster than inflation. Originally, the scope of covered entities that were allowed to participate were narrower than they are today. They consisted of disproportionate share hospitals and a universe of safety net providers like FQHCs, Ryan White Centers, Title IX planning clinics. And the original program basically said that if you had an in-house pharmacy, you had to utilize the in-house pharmacy to distribute the drugs under the program. If you didn't have an in-house pharmacy, you could contract with a single outside pharmacy to provide drugs to patients. And again, there have been significant changes around that we'll talk about in a second. Next one, please. So the program changed a couple of times, at least in 2006 and as part of the ACA in 2010. And in both instances, these changes resulted in the expansion of the businesses and entities participating in the program. One big expansion was covered entities to include more types of hospitals instead of just disproportionate share hospitals. Critical access hospitals, sole community hospitals, standalone cancer centers could participate as covered entities. And also coverage of child sites. So a hospital system or a health system that owns clinics and other facilities that exist outside of the four walls of the hospital can take advantage of the 340B discount. And again, one of the huge expansions was the availability of contract pharmacies. Really the door has been opened up very, very widely now that allows covered entities to use any number of contract pharmacies. Next slide. And again, the results have been significant. The number of covered entities overall has grown from about 8,100 in 2010 to 50,000 in 2020. Hospitals accounted for 10% of covered entities prior to 2004 and now account for over 60% of covered entities. And the actual dollar value of the sales related to hospitals has gone up and is now 78% just for DSH hospitals. And obviously the changes in the ability of covered entities to use contract pharmacies has led to significant growth in the number of contract pharmacies. You can see that number there from 1,300 in 2010 to over 30,000 in 2021. And one of the results of this is that you also now have very, very large for-profit businesses, large chains like CVS, Walmart, and Walgreens. Now make up 58% of the contract pharmacy locations. So again, you started out with a program that was very, very focused on a participation by a small number of not-for-profit entities, and now you have these very, very large for-profit companies that are participating as contract pharmacies, not as covered entities, and with a very big financial stake in the program. Go to the next slide. I'm not going to describe this slide, but it's goes back to a point that I'm sure those of you that work in the pharmacy supply chain understand is one of the things that states grapple with as they have conversations around topics like this is just how complicated the distribution chain and the supply chain are. This is particularly true for pharmaceutical products. And again, now that you have so many different types of business entities participating in 340B, you not only have the contract pharmacies and the hospitals and the other providers, but you also have these administrative entities like split billing vendors and who try to figure out where the money goes between the different business entities, and it just becomes a very, very difficult thing to untangle, and policymakers are working very hard to try to understand this. Go to the next slide, please. And this is and again, this just shows you in graphical form the extent of the program growth. It goes back to the first point that I made that if you go back 2015, the purchases at the discounted rate were about $12 billion a year. If you go back in time 5 years later, 5 years before, it's even smaller than that. And now, if you go into 2022, $53 billion. Of pharmaceutical products are being purchased with the 340B discounts. It has just become a very, very big program, one of the biggest pharmacy programs in the country, which again is why I think state policymakers and federal policymakers are paying so much attention to it now. Next slide, please. And as it's grown, you can see that hospitals account for an awful lot, really the lion's share of program purchases, and other grantees, such as the health centers, the Ryan Whites, the HIV clinics, have certainly significant purchases, but much smaller participation than the health systems and the hospitals. Next. So what have the states been doing about this over the last few years? So overall, a lot of the state activity in terms of trying to address pharmacy costs have been around regulating pharmacy benefit managers. And this has been true specifically in the 340B world. As 340B has grown, healthcare purchasers, insurance companies, ERISA plans know that when they're negotiating, that the providers they're negotiating with are buying their pharmaceuticals at deeply discounted rates, and want to try to factor that in. And a number of states have enacted what are known as these anti-discrimination laws, which prohibit PBMs from discriminating in terms of offering lower reimbursement or requiring people to use certain pharmacies and not contract pharmacies. Really trying to make sure that the value of the 340B discount is retained at the level of the covered entities. And these the slides that I sent over this morning updated this number a little bit. Bills have been enacted in over 20 states. I know Connecticut enacted a bill. A bill was enacted in Iowa this year, in Louisiana and Nevada. These bills have definitely been trending, and I think now we're up to over 24 states, or about 24 states, that have enacted those types of bills. A couple of states have also enacted legislation that prohibits drug manufacturers from trying to limit the ability of 340B drugs to flow through contract pharmacies. Louisiana and Arkansas have passed that legislation. I know that legislation was under discussion in Connecticut this year, and those laws in Arkansas and Louisiana are the subject of litigation in the federal court in those jurisdictions. And then I think the next one is my last slide. This year, for the first time, and again, I know this was a topic of conversation in Connecticut, for the first time we saw states looking at transparency legislation, again, as a way to try to understand the value of 340B within their state and how those dollars are being utilized. So in addition to the bill that was under discussion in Connecticut, there are actually 3 states that this session passed legislation that requires some level of reporting by 340B covered entities. And all 3 of these bills that passed have got similarities, and they've all got differences. They weren't based on any type of model legislation. Up in Maine, beginning in 2024, hospitals, not any other of the covered entities, but hospitals are going to have to report, these reports are going to be made public, their annual estimated savings from 340B, comparison of their savings to their total drug expenditures, and some examples of the hospital's top drugs. And they're also going to be asked to describe how they're using those savings for community benefit. Minnesota, also beginning in 2024, is going to require all covered entities, not just hospitals, to report at an aggregate level information on their 340B acquisition costs, the reimbursement they received as a from 340B drugs, and what their payments are to contract pharmacies. In addition, hospitals are going to be asked to report the same information with respect to their top 50 drugs. And in Washington State, for covered entities that receive Medicaid funds, which I would imagine is a pretty much an overlapping set, the healthcare authority is told to establish an annual reporting requirement for all covered entities. And they didn't really give the HCA in Washington State much more guidance than that in terms of the language. So they are working right now in terms of trying to figure out what they're going to do for that reporting. So maybe, I don't know if I wasn't watching the clock. I don't know if I took up a lot more of the time than I was allotted, but that was really the information I was hoping that the folks could have today. And I can try to answer some questions, or certainly dig up some answers if I can't answer them.
You were perfectly on time. So that was great. Thank you. And that was an excellent overview. Really appreciate it. I know it's a very complicated program. I think some of us will probably print out that slide that you shared and put it on our walls and stare at it to try to figure out the program. So appreciate that. So we have a few minutes for questions before we move on to our next presenters. So let's take a couple of minutes and open the floor. Guy has his hand up.
Great, Drew, thank you very much. Guy Wolfson, Medicaid Director here. Very informative presentation. Just a clarifying question. Given the federal nature of the program, beyond reporting, which is very helpful to see those examples, and I can certainly understand why some states have thought about that. What are the policy options available to states beyond reporting, if any, given the federal nature of the program?
Yeah, that's a great question, and again, I think that issue is part of the litigation that's going on in Louisiana and Arkansas right now. I think the states that are requiring reporting are really doing it, for the most part, really to build understanding. Right. And I can't say that I think the states are going to try to change the 340B program, because it is a federal program. But I think as states explore other policy options around drug pricing, as I mentioned, like there are bills that have moved in other states around these prescription drug affordability boards, which I think maybe some of you are familiar with. And then prescription drug affordability boards basically is sort of a rate setting process for drugs. And I think states have been a little surprised that more people haven't embraced the concept who they think would normally benefit from lower drug prices, right? And so, for example, a bill like that will move, and the goal is to bring down the price of drugs. And you'll see, covered entities not opposing necessarily the bill, but really questioning, like, what is this going to have as an impact to me in terms of being able to participate in the 340B program? And I think the states don't have the data readily in front of them in order to answer that question. And another issue is I think I alluded to briefly is I think that states perceive this program as a program that was originally designed to make sure that people who have a hard time accessing drugs, primarily because they have low incomes, are able to access those drugs. And I think they want to understand how it plays into their efforts to create greater access. And then I think you'd understand as a Medicaid director, I think this issue about as states are thinking about carving in or carving out their drug benefit, especially the managed care states, understanding that issue has been a big deal in states like New York and California.
Yep, that's helpful, Drew. And we don't have managed care here in Connecticut, so I was trying to think about translating your slide to our Medicaid land. But I asked my questions. I want to give Senator Summers the opportunity to ask hers. So,
thank you.
Thank you, Senator Summers.
Great. Good morning, and thank you for your presentation. From a practical standpoint, I will say I wish this committee or this working group had representatives from pharma and from the PMPs. I think that would have been helpful in the conversation if we are going to come out of this with recommendations for legislation, because when it comes to legislation, it's a whole different bailiwick, so to speak. But I did have a question on the lawsuits. Do you know, or can you give us an update on where those stand right now? That was a big topic of conversation during the last legislative session, in the fact, like what Guy had just asked before, what opportunities does the state actually have when this is a federal program?
Yeah.
And where those lie. And transparency, I think, has been very important in public health. And where are those dollars going? The intent of this, as you said, was to provide those, I'll put, most vulnerable populations with accessible pricing for prescription drugs. But it really has exploded, I think, since the contract pharmacy has been included as a entity that can be in this reimbursement world. And I think having the oversight and being able to know where those dollars are going and if they're allocated appropriately. I come from this world in a different way, and I know hospitals have used this money for, capitalization funds, et cetera. So I think that's really important. I'm just wondering if you could have an opportunity to speak to where those lawsuits are, because I think that will be very helpful in our determination. I don't know if you can, but if you could, that'd be awesome.
I at a very high level, in the ARC, I believe, unless something's changed like very recently, I believe that in Arkansas, the state was able to successfully defend its statute in the district court, and it's now under appeal in the circuit court. And I think they've had oral argument in that. And then I think in Louisiana, that bill just passed in the most recent legislative session, Senator. So I think that pharma has sued the state, but I don't think there's been much activity or certainly not any kind of decision in the district court yet. I think people expect maybe that the Arkansas decision will be decided very shortly.
Okay, thank you for that.
You're welcome.
I'll just respond really quickly, Senator Summers. I think your suggestion is a great one, to have representatives from the industry participating. We did reach out, and maybe we didn't have the right contact and didn't get a response. So if you do have any suggestions, I'm happy to take them, or we can work with our legislative team to reach out again and have them participate on the group.
Okay, great. Or at least they could at least listen in and offer maybe, I'm sure, a differing opinion in some cases, but I also think moving forward with whatever the outcome is of this particular group, and I'll be quick, the legislature does not understand how 340B works at all. They think that you just go in and you get like a discount card. They don't understand, how the first purchase is made, how the reimbursement goes to the contract entity. And I think that needs to be as painful as it is explained in greater detail. Thank you.
Thank you. Guy, is your hand up from the previous time, or did you have another question? Okay. I know I want to be mindful of time, and we have a few more presenters that will have shorter presentations. So I want to move on to our next presenter, I don't know if it's going to be Herman or Nina taking the lead, or maybe it's both of them. So I'll start with Herman.
Hi, good morning. Thank you for having me. So as the Medicaid program, we are diligent to ensure that there isn't duplicate discounts. So based on a file that we received from the feds, we look at that. It's called the Medicaid exclusion file, which you may all be familiar with. And we use that as a basis to exclude claims from rebate. Manufacturers are quite aware of claims, and certainly where they feel that invoices is incorrect, they let us know. But our task is to primarily make sure that claims and rebate is billed and invoiced correctly, and that we receive appropriate funds. Thank you.
Thanks. I'll pass it over to Nina and then open the floor for questions for the DSS team.
Yeah, and just to piggyback on what Herman was specifying, because Herman works for the pharmacy unit at DSS. I'm Nina Holmes. I am a social service manager of the Medicaid medical policy unit. Deal with mainly medical professional billing, physician offices, clinics, hospitals, those types of settings. And so we work with Herman's team to ensure that the claims in which are billed by those practitioners that are eligible for 340B status are also excluded from that, the double dipping duplicate discounts, so that they are on the rebate exclusion file. And if there's instances where there's some discrepancies, we work with his team to resolve what those potential discrepancies are and make any system updates and changes that need to be made to ensure that we are not double dipping and taking a duplicate discount. On the medical side, for some entities which were known that are 340B providers, there is a specific reimbursement rate for those entities, for those specific entities and or specific drugs that are billed that are 340B eligible under the Medicaid medical professional billing services.
Thanks, Nina. I don't know if anyone else from the DSS team would like to add. This would be a good time. Otherwise, I'll open up the floor to questions for the DSS team. Okay, so any questions for the DSS team? And if helpful for this group, we can probably provide a little bit of a quick summary and primer of DSS's role in this space, just so folks have it for reference. And by primary, I mean something written that summarizes what was just talked about. Okay, seeing no questions, I want to move on to presentations by our partners. I would like to start with our FQHC partner, represented by Sabrina Griswold. If you want to take a few minutes about describing how the 340B program operates in your organizations, that'd be super helpful.
Yeah, absolutely. Everybody can hear me, I'm assuming. Great. So I'm Sabrina Griswold. I'm the Director of Pharmacy for First Choice Health Centers. We have, I think, 13 medical sites. The number changes every once in a while, but we have 13 sites across East Hartford, Vernon, and Manchester. We also have school-based health centers where we're able to integrate within the schools and provide medical and dental services to students that may not be able to get to appointments otherwise. So we offer a wide array of services. We're primarily a primary care organization, but we also have behavioral health, women's health, OBGYN services, pediatrics, podiatry, nutrition, chiropractic care. We have an LGBTQ+ center, along with medication-assisted treatment, care coordination, and women's health, like I had mentioned earlier. Our 340B program started back in 2005, so it has been around for quite some time. I started here in April 2019, and at that point, we only had 2 contract pharmacies, and we did not have an in-house pharmacy at all. I worked to expand that, kind of similar to what Drew had said, right? So we kind of increased exponentially, and we were at our highest in January of 2020, where we expanded out to 16 contract pharmacies. And then in March of 2022, our in-house pharmacy opened. At this point in time, we have our in-house pharmacy and 14 contract pharmacies. Our 340B savings that we have realized through the 340B program allows us to expand our offerings to any area really that we see in need in our community. So most recently, our LGBTQ center has opened, and we've been able to offer more care coordination services with 340B funding. But in addition, medication-assisted treatment. So we have extremely long waiting lists throughout the state for patients. So we were able to facilitate an outpatient program, and it allows us to treat those patients that are most in need, and kind of fill in a gap for an epidemic that's happening across the country with opioid use disorders. We also, this is pretty cool, have been able to offer optometry services. So that's a fairly new program that our 340B savings has helped fund, and retail vision services. So we have an optometrist on site. She's got a pretty long waiting list. She saw about 1,700 patients last year alone, and her wait list is over 100 patients deep. With that, we open the retail vision services, so we're able to provide low-cost eyeglasses to our patients that otherwise couldn't afford eye care. It's a really, really great program. Our patients absolutely love it. And then in addition, we're able to open more buildings and facilities to really integrate within those neighborhoods for patients that don't have transportation or otherwise unable to really make it to their appointments. So one of our locations opened kind of in the middle of COVID in October of 2020. Last year alone, we had over 10,000 patient visits at that location. It's where our optometry site is. We have medical, dental, and pediatrics. So with the 340B savings and kind of its purpose, right? The purpose of the program is to provide more comprehensive services and stretch those scarce federal resources. We're able to kind of take our health center and integrate it within the communities and neighborhoods that are most in need, and really offer services that our patients need. With the manufacturer restrictions that we were talking about a little bit earlier, just to kind of give my viewpoint on it, Connecticut's a fee-for-service state. And full disclosure, I sit on the P&T committee as well for Connecticut Medicaid. So just want to let everybody know that. We're a fee-for-service state. So in order to, when the manufacturer restrictions first came out, they basically indicated that the purpose of gathering all of this patient data and placing these restrictions was to decrease duplicate discounts. If I'm correct, I believe there's only 3 fee-for-service states in the US at this point, and Connecticut, is one of them, and I appreciate that. So in order to prevent duplicate discounts, covered entities or pharmacies will have to have a different NPI to appear on the Medicaid exclusion file that Herman had referenced earlier in order to indicate that those 340B rebates are being captured ahead of time as opposed to after the fact with Medicaid coverage. I think, and Herman, correct me if I'm wrong, in my conversations with Carly and Joe and DSS, there are very few pharmacies in the state of Connecticut that provide outpatient drugs that have 2 NPIs. I have an in-house pharmacy at First Choice that does have one of those. The duplicate discounts, in my opinion, aren't necessarily happening. So in the state of Connecticut, because of the way that the program is set up, so it almost seems like the intent of pharma and providing these contract pharmacy restrictions, it's kind of a moot point in Connecticut. In order to have a duplicate discount, then you have to be billing Medicaid patients for 340B drugs, and it's not happening on the outpatient covered entity side of things. So I'm curious to know, Drew, what your thoughts are on that. But that's my opinion and my thought process. It logically doesn't make sense. It might apply for MCO states that have multiple PBMs that are facilitating their pharmacy benefit program. But in the state of Connecticut, it's one BIN number, and we completely manage our pharmacy formulary. So it doesn't really make sense what pharma's intent was to apply this designation. So that's what I've got.
Herman or Drew, I don't know if you have an immediate response, but we can certainly look into some of those questions.
Yeah, I don't really. I mean, again, I do certainly agree with Sabrina that there's nuance between, obviously how these issues would impact the small number of fee-for-service states, versus the managed care states.
Thank you, and I would also agree with that. I think being a fee-for-service state makes us a little unique from many of the other states, and having one one PBM for where claims come in certainly also make things a little uncomplicated. Where for Medicaid we can track things much more efficiently.
Thanks, Sabrina. That was really helpful, and I think something that we will certainly follow up on. I'd love to understand a little bit more the landscape in terms of overall how FQHCs are, kind of using the program to deploy some of these beneficial programs that you talked about. I want to be mindful of time. We only have 9 more minutes, and we have one more presenter, and then we want to make sure we have 5 minutes for some wrap up and next steps. So, Paul, I'll pass it over to you.
Good morning, everyone. Paul Kidwell with the Connecticut Hospital Association. I'll be very brief to that 5 minutes that Mehul talked about. So all but one hospital in Connecticut that participates in the 340B program participates through the DISH eligibility level. That number is about 15. It fluctuates dependent on DISH percentage that's statutorily required. Connecticut Children's Hospital is the one hospital that has it as a children's hospital is able to participate via that part of the statute. Just to note, for-profit hospitals are not eligible to participate. So we have 3 hospitals like that in Connecticut that are not eligible to participate based on just virtue of them being for-profit. As Sabrina noted, our hospitals use the savings to stretch scarce federal resources. So as you may know, not-for-profit hospitals report to the IRS on an annual basis related to Medicaid underpayment, uncompensated care, community building activities, community improvement activities. In Connecticut, that uncompensated care number is approximately $243 million on an annual basis, with close to $1 billion in Medicaid underpayment. That certainly those 340B savings are used to support. I just want to note one item that is going on outside of the 340B program that you may be aware of, related to Medicare reimbursement for hospitals. So starting in 2018, Medicare reduced reimbursement for 340B drugs in the Medicare program. There was a lawsuit that went to the Supreme Court. Supreme Court found that CMS had inappropriately reduced those payments. And so just this week, or late last week, CMS finalized a rule to remediate that underpayment. But I just wanted to note it because it's out in the universe, and it is certainly associated but not part of the 340B program as far as its operations. I think, just mindful of time, that's the 20,000-foot level look at hospital participation in the program. Certainly happy to provide additional detail in future meetings or offline.
Great, thanks so much for that. We might have time for one question if folks have a question for either Herman or Sabrina. And I think what we'll do on our side, DSS is sort of coordinating this report, is that we'll compile everything we heard, and then, as part of the subsequent meetings, I might as well move on to agenda number 5, is just to talk a little bit about what the next meetings will look like. First, in terms of substance, we will take what we heard today, plus whatever other resources we have, apply them to the provisions of the statute that we're aiming to fulfill, and then identify an agenda for the next meeting that will help us kind of either double click on some things that we heard today or review some things that we didn't hear today that would be relevant to our report. So that's big picture how we're hoping to move forward with the agendas for the next meeting. So I don't have the agenda set up because we want to process what we've heard today. Scheduling these next meetings is going to be difficult, so I don't want to underestimate that challenge. But in terms of timeline, what we're hoping to do is have a draft version of the report by the end of the calendar year, understanding that the final report is due at the end of January. That being said, we should aim to get 2 additional work group meetings, if at all possible, by the end of the calendar year. It seems, I don't want to assume, but if this time works for folks, I think my kind of opening gambit on scheduling is to have a 9 o'clock meeting on Tuesday, November 28th, which is the Tuesday after Thanksgiving, and then another 9 o'clock Tuesday meeting on December 19th. You don't have to respond yes or no right now, but I think that's what will work as an operating assumption that hopefully will work out, and we'll coordinate on our end with our admins to get those times held. And if for some reason it just doesn't seem to work out, we'll work on getting other times. Does anyone have concerns about that approach? Great. In terms of the next steps in gathering feedback, it would be definitely very helpful for us if you have anything written or resources that you feel are really germane to us fulfilling the items and the provisions in the statute. If you could send those our way at any time, the sooner the better, and that can help us kind of process and help us begin to draft the report. We'll also make a point if there's something that we think, oh yeah, this person will definitely know, or your connection may know that what you want to put in here. We'll reach out individually to folks as well. But in the meantime, feel free to send things over our way.
And just a caveat, make sure you're comfortable with that being publicly posted. We're trying to make sure this is an official working group of DSS established by statute. So send whatever you'd like, but assume we're going to post it publicly.
Thanks for that, Joel. Appreciate that. And I know I had logged one follow-up item on our end with the Senator Summers. I'm happy to follow up with you or your staff directly to identify someone if we want them to invite them to participate on this group from the industry side.
Okay, I'll see what I can do. Maybe there's a reason that I'm not aware of. Maybe there was a disconnect on who was reached out to. I'm not sure how that worked, but I'm happy to try to help.
Perfect. Thank you. Appreciate that. Any questions on process? Okay. Our final agenda item before adjournment is other business. So the floor is open if folks want to raise any other issue relevant to our work group. Going once, twice. Okay, hearing no additional items under other business. I don't know that we need to follow Robert's rules for this, so I think I'll just not set that precedent and go ahead and adjourn today's work group, and you will be hearing from us regarding the scheduling very soon.
Thank you.
Thank you, and thank you to all the presenters. Appreciate it.
Thank you.
Thank you.